Michael Thase. I'm a professor of psychiatry at the Perelman School of Medicine, where I'm also a member of the medical and research staff at the Corporal Michael J. Crescent's Veterans Affairs Medical Center. I have been a professor of psychiatry for a long time. I do mood disorders research, and I think that's what we're going to be talking about today. This year was the year of maturity, if you will, of the phase 3 clinical trial program for lumateperone. And lumateperone, of course, is the next to most recent newer generation antipsychotic. But like several other members of the second or third generation of newer antipsychotics, it has a better a better reputation, more likely to be used in people with mood disorders than in people with schizophrenia. And in particular, lumateperone had really a compelling set of studies done in bipolar depression, and then ending in the 2025 FDA approval of lumateperone, 42 milligrams as an adjunctive therapy for people with major depressive disorder. The really strong evidence that this particular medicine can reliably increase the chances of someone who hasn't responded to one or two conventional antidepressants can have a really good chance of feeling a lot better within 2 to 4 weeks and having reasonably good tolerability, even though this class of medicine, I mean, one concern we've always had is balancing the potential side effects with the benefits. And so one of the posters I reviewed really looks at metabolic side effects and extrapyramidal symptoms and so forth in the two main pivotal trials of lumateperone. These are adjunctive therapy trials in patients who have with major depressive disorder who haven't responded to conventional antidepressants, and then they're placebo controlled, and patients are randomized to either a placebo or 42 milligrams of lumateperone. And in the tolerability trials, really there's a minimal amount of weight gain and a very, very small signal for metabolic disturbance in terms of, for example, elevated lipids or elevated cholesterol, or for even increases in body weight. So compared to some other medications in this class, a fairly good and reassuring metabolic profile, as well as a low risk of extrapyramidal symptoms. So as this is coming, our first adjunctive treatment studies with newer generation antipsychotics happened back more than 25 years ago with olanzapine, and then moving forward with aripiprazole, quetiapine, and so forth. So here we are 2 decades into this era, and we do now have some potentially safer medications. So you must balance the good that the treatment does against the potential risk. And so knowing what the chances are that the treatment will work is one of the ways of gauging the good that the adjunctive treatment does. And so a second poster presentation at our spring meetings was a network meta-analysis, which took not only the studies of lumateperone, but also compared a number of other studies, placebo-controlled, of adjunctive newer generation antipsychotic medications. And we sort of knew what was coming just based on what we'd seen in the individual publications. But believing what you see and looking at a well-analyzed and inclusive and comprehensive set of data is a whole nother story. And I'm pleased to say that the network meta-analysis also similarly confirmed that the average benefit for people randomized to adjunctive treatment with lumateperone 42 milligrams once a day was on the order a higher chance of benefit or a higher chance of effect compared to other medications studied in this area. Now, we are not talking about giant night and day differences, but we are talking on average modest advantages when you couple with the favorable tolerability profile. I think is a real good reason to think of this new addition to our therapeutic armamentarium as a useful and valuable one. So one change in the kind of way of thinking about difficult to treat depressions is to move a little bit away from a strict medical model in which you think our patient has a discrete illness that is resistant to a treatment that should have worked for that illness. And so that's kind of the model when 30 years ago when we came up with a staging system for treatment-resistant depression. And we now realize that people don't respond to treatments for depression because depression's a pretty heterogeneous set of conditions, and our specific proven treatments typically work through one or two discrete pathways. And so the fact that you may have an illness that doesn't respond to a treatment that works in one way doesn't mean that you might not benefit from other treatments that work through different relevant pathways. And so I think we now move towards thinking about a broader construct called difficult to treat depression, in which people's past history of trauma or their histories of medical complications or other significant comorbid psychiatric disorders might also contribute to whether or not a standard treatment will work or won't work for them. And so from this broader viewpoint, you might think of other interventions outside of antidepressant pharmacotherapy or adjunctive pharmacotherapies that are demonstrated to work for some people, and also think of a broader array of treatments. And so here's where the future may be open for a subset of people who may not respond to medications that target serotonin or norepinephrine or dopamine, but may work through other pathways, including those treatments that we conventionally call psychedelics. And so here, under the difficult to treat depression rubric, when you think of medicines like the newer generation antipsychotics, there's several different pathways for which they may help a particular difficult to treat patient, including having an illness that falls within the bipolar spectrum, or having significant co-occurring anxiety, or having some history of a particular trauma or kind of stress modifying illness that has affected you now for 20 or 30 years since the original event. And so the notion that the newer generation antipsychotics are fairly consistently shown to have adjunctive value may in fact reflect a broader array of potential benefits for patients, and including the notion that lumateperone may have more input or more effect on glutamatergic systems than many of our other newer generation antipsychotics. So I think we had a period of we moved from a modernist view of what we knew about psychopharmacology and what we thought would work to a more sober postmodern view over the past 20 years. And what's happened in the last decade is really a sense that there are areas in which therapeutic activity may be recruited from non-conventional ways. And so this has kind of come along with a level of excitement for psychedelic therapies that has brought new kind of interest and enthusiasm into the field. And so I found this year's spring meetings to be more upbeat and full of potential therapeutic optimism than many meetings over the past couple of decades. And I really look forward to what's ahead for us.